That's why in the Erasmus MC we're starting on March 7, the day before International Women's Day.
Uh-huh.
We are starting a Women's Health Research and Innovation Center because we really would like to have more focus on not only research, but also bringing innovations into the market that truly benefit women right now.
Welcome to Women Disrupting Tech. My name is Dirk-Jan Hupkes, and on this podcast I give the women who work in tech the platform they need to inspire and empower each other. Join me on a journey into the world of entrepreneurship, funding, biases and role models to discover the strategies for success in the tech industry. In other words, how women can disrupt tech. Are you ready to listen? Hey, welcome back to Women Disrupting Tech, and thank you for listening to episode 87. I want you to imagine the following situation. A woman walks into the doctor's office and she complains about back pain. She's sent away and she's told it's stress, maybe menopause, doctor doesn't know. An hour later, a man walks in with the same symptoms and he is sent straight to the hospital for testing. Now, this is not an exception, this is what is called the women's health gap. Because for centuries, healthcare has treated women like small men, from research to diagnoses to treatment. As a result, women are diagnosed later, they receive the wrong treatments, the wrong medication, have more side effects, and they spend more years of their lives in poor health. But there's also a monetary cost to this, because fixing the women's health gap would grow the global economy by $1 trillion every year. So, how do we change this? This is where my guest in today's episode comes in because Professor Hanneke Takkenberg's mission is to close the health gap between men and women. In this episode of Women Disrupting Tech, Hanneke Takkenberg shares her journey from cardiac surgeon to DEI advocate. She explains how gender bias in medicine affects careers, patient outcomes, and leadership. Among the topics that we discussed are the hidden gender gap in medical research and treatment, how shared decision making can improve patient care, the long term financial impact of unequal pay in academia, and why AI and data in medicine must be more inclusive before we can start scaling. Plus, you'll hear about Hanneke's initiative to improve women's health that will be launched on 7 March 2025. So when you're ready to listen and learn how breaking barriers in medicine and leadership can improve women's health, please welcome to Women Disrupting Tech, Professor Hanneke Takkenberg. Hey, good morning, Hanneke. Good to have you. Welcome to Women Disrupting Tech. The question I always start with is how you got into your current job or current position, and the floor is yours.
Well, thank you. It's a pleasure to be here today. Well, how did I get into my current job is actually quite a long story, and I will give you the executive summary of that.
Mm-hmm.
I started as a medical doctor in 1994, so over 30 years ago right
Mm-hmm.
now. And back then there were no jobs, so I moved to the US, spent time in Los Angeles in a heart transplant team. And I've been into heart transplant and more into general cardiac surgery ever since.
Okay.
First as a clinician and later on as a researcher, which I still am. And when I came back to the Netherlands after 3 years, I ended up in the Erasmus University Medical Center as a researcher physician in the Department of Cardiac Surgery. And I truly enjoy that because the work that we do, and I still work here at Erasmus University Medical Center, the work that we do is so meaningful for so many patients. At the same time, there's so much to improve, and I'm really research minded, and I like improving things, making things better for people. Especially decision making. And in 2012, I became a professor of clinical decision making in cardiothoracic interventions in my field. So, how can we make better decisions with and for the complex patients that we are treating. And you may think, what does that have to do with my other job? Because since 2000 and I think 2018, I'm also a professor of management education with a specific focus on women and
Hmm.
organizations. Well, it very much has to do with each other because in my junior years in the Erasmus MC, what I noticed is that in my organizations, things weren't as fair for women as they were for men.
Hmm.
And I would see male colleagues make next steps in their career. And I would see female colleagues really getting drowned into work and balancing their lives, combining clinic research with also parenthood. And one day, I think it was in 2006, I noticed in the social annual report of the Erasmus MC that women were making less money than men. And that really outraged me in my own center. So I wrote an angry email to our board of directors and the head of HR. And the next day I got a call from the only and the first female board member of the Erasmus MC, Charlotte Insinger. And she said, well, let's talk. And ever since I have been involved actively in what was first women's policy in the Erasmus MC and has now become diversity and inclusion
Yeah.
policy in the Erasmus MC. After a couple of years, my dean, Huib Pols, became director magnificus of Erasmus University, and he invited me to join him for a day and a half a week to become chief diversity officer for Erasmus University. That's where I met. This is a long story anyway, and I'm giving you the short version. That's where I met Professor Diane Beverlander, who had just started Erasmus Center for Women and Organizations. And we became friends, and I joined her in her efforts to advance female leadership in organizations and really to strive towards gender balanced leadership into any organization. And I guess that's what I'm doing right now. I'm combining, on the one hand, my work in the Erasmus MC, that is a lot about male female differences in health and disease related to the heart. But I'm also starting a Women's Health Research and Innovation Center this year. And on the other hand, I'm running right now by myself because Diane passed away in 2021 after
Yeah.
a long battle against cancer. I'm also leading Erasmus Center for Women and Organizations, where we not only try to advance women in their leadership positions, but really to transform organizations towards sustainable, inclusive organizations.
Okay. I want to pick up on one thing you said. You wrote at some point, you write in a really angry email about the difference in pay at the Erasmus University. How is that now? Has that is that more equal now, or is it equal? Equal pay for equal work? Or is there still a difference?
The good thing is that they're looking into it and they're trying to understand where there are differences in remuneration
Yeah.
between men and women. And of course, it also depends on the position that you're in. But whether it's already narrowing that gap, I don't know.
Okay.
I do know that there's currently research going on in the Erasmus MC into the payment of men and women who work for Erasmus MC. The same applies to the university. Between 2018 and 2023, I was the chair of the Dutch network of women professors in the
Hmm.
Netherlands, the
Yeah.
LNVH. And we also did research into remuneration, not only monetary, not only the money you
Hmm.
receive,
Yeah.
but also the other privileges you may or may not have as an academic. And what we
Like.
found is, well, for example, do you have a secretary? Do you have your own office or do you share office space? Do you get extra income through other activities next to your work?
Hmm.
That sort of stuff. And we did see on all fronts, both when it came to your paycheck, but also to the more invisible differences in remuneration, we saw clear male female differences to the benefit of men.
Hmm.
So men make more money in academia. and they still do. And if you look at that over the length of a full academic career, it's like hundreds and thousands of euros. And that also, of course, then has an effect on your pension. So it's a big problem. The same has to do with the fact whether you have support, whether you have your own office, whether you have these extra incomes. So there are differences, and they seem to be not so big, but if you add them all up, they are really a big difference.
And a second thing you said was if you're looking into how can shared decision making help improve medical decisions, treatments of complex patients. Let's first start with what is the effect of not having that on a patient? Can you give an example what that means?
If there's no shared decision making,
Yeah, if it's like a very small homogeneous group who does that, man.
but I think when I look at shared decision making and when I look at diversity
Hmm.
and equity and inclusion, I think they're very tightly related.
Hmm.
I think that the perspective of a medical doctor may very well differ from the perspective of a patient.
Hmm.
If I look into my own field in cardiac surgery, what our surgeons want
Hmm.
is to do surgery first
Yeah.
and foremost. And then, of course, they would like to technically operate a patient in such a way that it's a really durable result,
Yeah.
so that it will benefit the patient with regard to the risk of dying,
Hmm.
make it as low as possible, risk of having complications later on after surgery. So that's important for the doctor. But for the patient, it's a completely different thing. They want to know, hey, doctor, am I going to live? And if I'm going to live, will I be able to do what I am used to do? For example, work, uh, care for family members, have an active participation in society. So that's a different thing. And also, in that respect, these perspectives, the doctor's perspective and the patient perspective, if you don't understand both of them, you cannot optimally treat a patient. For example, if you have an elderly person who really wants to see their grandchild born, you make a different decision than for a young person who has a whole life ahead of them.
Hmm.
So it's about, so how can you tailor treatment to not only clinically treat a patient better, but also treat the human that is the
Yeah.
patient
Also focus on quality of
optimally?
life.
Yeah, and sometimes that means you don't treat, and
Hmm.
that's difficult for a
Yeah.
lot of physicians. So there's a lot of overtreatment in the Netherlands, of course, also some undertreatment. But I do believe that if we have more meaningful conversations between doctors and patients where we truly understand each other's perspective, or at least try to understand, because sometimes it's difficult, then your decision making will become more effective rather than more efficient. I think that's what the key is when
Yeah.
it comes to
So,
diversity.
am I hearing you say that currently it's focused a bit more on effectiveness, whereas and it doesn't really take or takes to a lesser extent quality of life and the end result into account for the patient?
Yeah, well, I think traditionally in medicine, there has been a focus on clinical
Yeah.
effectiveness
Yeah.
and the more human aspects related to medical decision making have been ignored largely. And it's only in more recent years with the rise of value based healthcare, where we say it should not only give low mortality and low morbidity,
Hmm.
so less deaths and less complications.
Hmm.
No, quality of life is something we need to add.
Yeah.
And perhaps you want to go further than just quality of life. You also want to take a look at, so how can your treatment result in the person who is the patient being able to go back to normal life that is meaningful for that person?
Yeah. How is that? It's just out of curiosity. How is that different for men and women? Because from what I read and learned, there's also a gap in the effectiveness, but also in how we treat men versus women. And that. women may have totally different views on this as a patient, but
Yeah.
also different causes of cardiac problems.
Yeah, well, I think this is one of the great opportunities of our time. And I think in the next couple of years, my ambition at least is to close the health gap between men and women. Because what is going on is, and then this is a worldwide thing, is you see that medicine, she's actually a male, as we say. There's a
Yeah.
famous paper by one of my colleagues in the New England Journal of Medicine
Mhm.
stating that medicine is male. And that's true. And it's understandable because in the old times, women were not even allowed into medical school. So it were all men going
Mhm.
into medical school, becoming medical doctors, starting societies, building hospitals,
Mhm.
building practices. There has always been a focus, both in clinical research and in basic research, on taking the male perspective as the start point. So, experimental research in rats, only males. I've done that myself. I mean, back in the old days,
Uh,
done experimental research on heart failure and heart transplantation only in male rats. Never thought about it, that it might be different in female rats. But of course, you would not use female rats because they have a hormonal cycle that may disturb the results of your research. The same applies for clinical research, is that a lot of the clinical trials are predominantly done in males and not in females. And only in more recent years, there's now a movement that says we need to do something about it because we find out that in many diseases, including heart disease, that there are vast differences in the way the disease evolves, how hormones influence it, but also the way doctors, and this is more about gender than about sex, how doctors treat women. And if you go to your GP as a man, you get a different approach than when you are a woman.
in what
And
sense?
in what sense? I think there's more underdiagnosis in women than there is in men.
Because of hormonal cycles.
Well, that's there's many reasons, but it has both to do with sex and with gender. Sex is about biology,
Yeah.
about hormones, and the fact that we are way different, men and women. But gender is about socio-cultural constructs in our society. So if you have a profession that was started predominantly by men, and there's now 70% women in this profession, but not way up in leadership. That's a bit of the challenge. It's the other way around. We're a minority. What you then see is that the male construct rules, but also, and I think I should refer now to my colleague, Professor Angela Maas, who wrote a book, two books now about this, is that women are basically seen as little men. Well, we're not. And it's very hard to actually.
Is that the same as with the famous topic or a famous example that I know is crash test dummies, which are used to be men only, and then they thought, oh no, we have to do something with women. Oh, we just put breasts on top of them.
Yeah. No, 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 that's right. It's about the same. The sad thing about it is, so if you do trials and develop new drugs and you test them only in men and then you give them to both men and women,
Hmm.
it's not surprising that women get more side effects and toxicity compared to men, and that they're less effective in women. um, you need to take a deeper look into that, how you can better treat women. And I think the reason why it's so important, so it's both in recognition and in knowledge of doctors about the fact that there are male female differences, but also socio-cultural differences between men and women, and that you may overlook symptoms in women, for example, for a heart attack, because the symptoms are different for women than they are for men. And let alone that is causing a lot of women to die because of heart attacks, because they're not treated in time, because they're not diagnosed in time.
Because the man, the GP simply doesn't recognize the symptoms. Like, oh, this is a symptom that is specifically for a woman, an indicator of a possible cardiac arrest.
Yeah, so it's in there, and there's a lot of resistance as well because it makes things more complicated. And I think my own work, I've been working on a big research
Hmm.
project on thoracic aortic aneurysm, a dilation of the big artery that comes out of your heart, your
Yeah.
aorta.
Yeah.
And I found that in our database in the Erasmus MC, our database of surgery in these patients, because an aneurysm, you want to do surgery on time before it gets too wide and
Yeah.
just pops,
Yeah.
and then you die. So it's recommended to do this at 5 centimeters diameter.
Hmm.
And when I looked in the database here in the Erasmus MC, the men are operated on average at 5 centimeters. And I thought the women would be operated at a smaller diameter because women are smaller than
Yeah.
men. So you may want to take no risk. But women are actually operated at a larger diameter of 5.5 centimeters. And I was like, how can that be?
Yeah.
And that's probably because it's recognized later. And perhaps the disease process is different. So I went to one of our surgeons and I asked him, why do you think this is? I would say it should be at least the same and perhaps even smaller in women, this diameter. And then he said, I know why. It's because women are so hesitant.
In going to the doctor.
Yeah, and in wanting to have surgery. And I'm like, I think that's a really bad joke. It's probably because we are not as aware of women having this disease.
Hmm.
And perhaps the symptoms differ in women, and perhaps the rate at which the aneurysm dilates differs. And so that's when I started looking at it more with a large group of my colleagues in the Netherlands. And we found that indeed women present differently than men. Also, we find that women, when they have certain aneurysms, they progress faster than men do. And they are diagnosed at a larger diameter, so later than men. So there's many differences, but also quality of life is worse in women than in men who have this disease. And so there's
After
a lot of
surgery.
and before surgery. So, because if you walk around with an aneurysm, you probably are very anxious. And most people are also depressed because they're afraid it may burst. So, these are things to consider.
Is it something you feel? And how do you feel that you have this?
It's usually a diagnosis that is made coincidentally. For example, you need to have an x ray of your chest
Hmm.
and then they see the big aneurysm. But if it gets big enough, you get symptoms
Like?
like back pain, sweating, but that's at a really late point in time. You feel an excruciating pain. It can be that you feel nauseous. So there's all kinds of vague symptoms going on, and usually an X-ray tells you, and then of course, you do a CT scan and other imaging. It will tell you that you have an aneurysm. And with men, doctors are more likely to order an X-ray than with women. They say, "Oh, must be menopause. It must be
Yeah.
that you're so stressed, etc., etc., etc." Yeah.
Is stress, by the way, part of the causes?
High blood pressure is a big one, which is
Okay.
also underestimated in women and also undertreated in women. And all in all, you know what that does, not only to women's health compared to men, there's a big gap in health related quality of life. And you can calculate that in years.
Hmm.
So there's a loss of life in good health for women compared to men. Women live longer, but they live a way longer time in impaired health, also due to these kind of differences. Also, what it does indirectly is that it causes women to be less effective in the workplace because if you don't feel well, you're less productive.
Hmm.
And what that does to our economy is costing us billions a year. It's
Trillions even
yeah,
on
yeah.
a
So
global
it's
scale.
yeah, yeah.
There's an I think McKinsey did research into this last year, and they presented it, and I think it was sort of 1 trillion US dollar globally opportunity, which equates
No,
to about 12% or so. In the Netherlands, it would be 12% of GDP that we could improve by improving female health.
yeah, that's why in the Erasmus MC we're starting on March 7. The day before International Women's Day,
Uh-huh.
we are starting a Women's Health Research and Innovation Center because we really would like to have more focus on not only research, but also bringing innovations into the market that truly benefit women right now. One
Okay.
of the examples that we're already doing in the Erasmus MC is we have an outpatient clinic for our female employees who are in menopause. And they can go there, get advice, get treatment, and
Hmm.
in result, they feel better and they become more productive. It's it's
It's
these
like a
type of
miracle.
it's so simple. It can be so
Yeah.
simple. Yeah,
Yeah.
yeah, yeah.
Yeah. So on the innovations, because you talked about going into data some time ago, I was wondering what role do you think AI will have? And let me expand that a bit to AI and robotics, because I know that even in heart surgery, you told me before we started that robotics is already used.
So when I think of AI and I think of diversity,
Hmm.
I think there's still some steps to make because with AI learning systems,
Hmm.
anything that you put in will
Hmm.
come out in a different way. So if you put in garbage on the one hand, garbage comes out on
Yeah.
the other hand. So we need to make sure that if we start using AI, is that we make sure that it's not biased to start with. And then if you look back at what I told you about how medicine was built and
Hmm.
how hospitals were built and how medical data was built,
Hmm.
I think that's a first step. The key to effectively using AI in medicine and to the benefit of diversity
Hmm.
and inclusion starts there by taking really critical look at it. And it doesn't only apply to men and women, but I think there's also a famous experiment that had to do with people of color
Yeah.
that they simply did not recognize. AI has a big challenge there. At the same time, you see that the big corporations who are pushing AI are giving it some attention when it comes to diversity in the workplace.
Hmm.
So they start to work with that and start to realize that that is something that you need to take into account. But when I go back to medicine, I think that's our big challenge in the next couple of years is to make sure that we de-bias AI toward the norm of white males, etc., etc.
Yeah.
You know, in first world countries, I think that's a really big thing to do. At the same time, when I look here, we use AI in the Erasmus MC. In my own field, we use it to plan operations.
Hmm.
So, and to better understand the scans that we do before surgery,
Hmm.
and to be able to optimally use our operating robots in doing keyhole surgery. So it's there already, but we haven't looked really into the differences of how you can apply it safely and effectively in men versus women. So that's an interesting thing that we do need to take a deeper look into.
Yeah. So two questions on that. One is how can we start to de-bias the AI, because that to at some point that will come with data from, let's say, uh, other people than just white men.
Yeah, yeah, yeah. But so it's important, and well, the same as it applies to clinical trials and to experimental research. I think what we're trying to do is to make sure that before we start something, that we make sure that we have a diversity of data. It needs to be there, otherwise you cannot apply it to everybody.
Hmm.
The problem with the randomized trials that we currently do is that we usually have a selected population of patients who is entered into these trials.
Yeah.
And usually it's a majority of white men. And
Why is
right
that?
now, I guess they are more likely to be treated in those centers that are also academically active.
Hmm.
And I think that when you, so these was what we call tertiary centers compared to other people who get operated at more general hospitals that may not participate in those trials.
Because the hospitals don't know about it, or because the patients cannot find it?
Well, I'm not, well, especially if I
or
look
are not
into,
willing, maybe.
yeah, or are not able to travel so far, perhaps. Poverty also has something to do with it. So if you're rich and your postal code is a good one,
Hmm.
I think it will get you sooner into a tertiary care center than when you live in an area that is not
Like
so rich. So
like
I think
Rotterdam
there are,
Zuid.
yeah, Rotterdam Zuid, for example. So if you look at the famous Rotterdam street doctor Michelle van Tongerlo, I think she writes and also about this the fact that access to healthcare is not equal for everybody in the Netherlands,
Hmm.
although we claim it is. But it's also if you're highly educated, if you have more money, more resources, can apply, have more time. Yeah, and then you end up in trials more easily. And it may also be that due to, I haven't really looked into that, whether men versus women or people from different cultural backgrounds are more likely to want to be included in a trial.
Uh-huh.
But anyway, my point is that if you look at clinical trials, I think the same applies to AI. We need to systematically put more diverse people in these trials if we want to make any sense. That the problem is then we need bigger trials, and that's really a big challenge. So I guess the design of our trials needs to change as well. And I think the same applies for AI. Your starting point needs to be different, and you need to take that into account in your system.
I want to move towards closing. What is the role of men in this? Because you told me in the beginning that there are still some, let's say, hesitancy slash resistance against change in the medical profession. How can we, and I mean also not only women but also the men, how can we change this?
I think both men and women play a crucial role
Hmm.
in wanting to improve healthcare because we've only talked about healthcare right now for everybody.
Yeah.
I think the same applies to leadership, whether it's medical leadership or leadership in other types of
Hmm.
organizations.
Yeah.
It benefits both men and women to work on this because we do know that if you have a diversity of perspectives, there
Yeah.
we go again. The diversity of perspectives is essential in order for an organization to thrive. And not only because it's unfair to women or other marginalized groups, I don't think that's an important thing. I think equity is really important, and feeling included is, and being equally represented is, but not only for the sake of social justice. I think it also helps us to become better doctors, better leaders, and thereby treat all patients more fair and as humans. And I think that's the beauty of it all. I think that, for example, focus on women's health will also benefit men's health. Because if we better understand how women are different, we also get a clearer picture of what truly works for men. Because right now,
Yeah, you can
they're,
take out, let's say,
yeah, yeah,
you can really separate, okay, this works for men and this works for women, and you can make it
exactly.
more tailored. And the more by extension, I guess, the more data you have, the more diverse data you have, you can also do that for other underrepresented groups.
Yeah. And that's the thing. So it benefits everybody. The most important thing also that men should be involved is that right now it's still mostly men who are in leadership positions, so who can truly make change.
Hmm.
And technological innovation is beautiful, but it won't work if there's no social innovation. And social innovation means that we start changing our behavior for the better and that we start caring about everybody equally and that we thereby create systems that are fair to everybody, whether it's about AI, whether it's about business in general, whether it's about medicine or science. I think we all benefit. And therefore, it's so important for men to really get involved. And we see more and more visionary men do that. That makes me really hopeful. And then when I look at you, 32 is your target, I
Yeah.
believe.
Yep.
Well, let's work on that together.
Sounds like a plan. So, Hanneke, thank you very much for this amazing interview. Question I always close with is So I have this mission ending in 2032. What is your advice to me to make that happen, to make diversity, equity, and inclusion the new normal by the end of 2032?
I think what you're doing right now, already raising awareness and being a role model, is helping a lot. I think in your specific position where you talk to a lot of different people who are trying to reach the same goal, you would be in a perfect position to also connect them to each other and make them work together better. I think that's something we can improve on. There's a lot of initiatives that are scattered. And I think if there's a more strategic movement
Hmm.
to be built, I think then we can perhaps do 2032. I would love that.
Yeah,
And,
it's
and I would join.
okay. Cool. I'll hold you to that. Thanks again, Hanneke. Really appreciate the conversation. If people would like to learn more about you or your work at Erasmus MC or at Erasmus University or at ECWO, where would you like to send them?
Well, you can always Google me, and I'm on LinkedIn as well and on Blue Sky, but I'm still trying that out.
Okay.
And drop me an email or a message. And I'm always open to working collectively and also connecting people that have the same purpose. And I do believe in the end, DEI is a means to a bigger end. And that has to do with a better world for all, whether it's in medicine or in general, or when it comes to our ecological systems, etc. I mean, so that's how you can find me. Thank you.
And we'll include those links in the show notes. Once again, Hanneke Takkenberg, thank you very much for this interview. Listeners, thank you very much for listening. And until the next episode, keep being awesome. Well, that's a wrap. Thank you for listening to episode 87 of Women Disrupting Tech with Professor Hanneke Takkenberg on how breaking barriers in medicine and leadership can improve women's health. Hanneke and I hope that you've enjoyed our conversation as much as we did. And if you'd like to learn more about Hanneke and her work at Erasmus MC, ECWO, or Rotterdam School of Management, feel free to connect with her via the links in the show notes. As usual, you can find the show notes at womendisruptingtech.blog. On that same website, you can also become a member of the Women Disrupting Tech community. As a member, you get early access to new episodes, you get a handwritten email with the special moments of each of the episodes, plus you'll be the first to hear when new blog posts come online. So check out the show notes for a link. When you're looking for a role model to inspire your own hero's journey in tech, I invite you to check out one of the other episodes of this podcast on Spotify, Apple, and YouTube. And if you're a regular listener, please give the show a rating or a review because that way you help other people discover the podcast. If you're a male ally and you want to help the Women Disrupting Tech make this podcast obsolete by the end of 2032, there's a simple thing you can do. Please share the podcast with friends, family, and coworkers because this way you give my guests a platform they need to make it happen. Finally, if you want to connect with me, you can reach me via dirkjan at womendisruptingtech.blog or you can send me a DM on LinkedIn. On LinkedIn, simply type in my name and you'll find me. With that, I wish you a wonderful day. I hope to see you in the next episode and until then, keep being awesome.